Thank you so much, Howard. So next up, we have Dr. Meredith McCormack, who's the medical director of the Pulmonary Function Laboratory and associate professor of medicine at Johns Hopkins University School of Medicine. And she will be talking about pulmonary disease, and the title of her talk is Pulmonary Disease Associated with Fine Particulate Matter Exposure in Indoor Environments and Disparities in Economically Challenged Communities. Thanks, Meredith.
Thanks very much for the invitation to be here today. And I'm just going to take a moment to share my screen. Thank you very much. I'll be talking about the pulmonary effects of fine particulate matter with a focus on indoor environments and disparities in economically challenged communities. These are my disclosures, and they are not connected to the content I'll be discussing today. And as was just mentioned, this schematic on the left may be familiar to many of you. This is the relative size of particulate matter 2.5, fine particulate matter in the red, in comparison to a human hair or a grain of sand. And we see here on the right, the respiratory tract. And one thing that's very unique about PM 2.5 is the ability to penetrate deep into the lungs and to reach all the way to the alveoli. As Dr. Kippen mentioned, the small sacs where gas exchange occurs and the alveoli are in direct contact with the capillaries. And we know that the smallest components of PM 2.5, the ultrafine particles, are even able to translocate into the bloodstream. And when we think about the respiratory health effects of fine particulate matter, we can extrapolate somewhat from what we've learned about outdoor air quality. In particular, I wanted to emphasize the impact on lung development. And so when a baby's born, the lungs continue to develop all the way up until the early 20s, and the alveoli increase exponentially as children grow. And during that time, they're susceptible to the health effects of air pollution. And that's been shown with outdoor air, demonstrating that fine particulate matter exposure impacts the trajectory of lung growth and is associated with an accelerated decline in lung function as we age, which we see over here on the right, and that improvements in air quality can lead to improvements in that optimal lung growth and to an attenuation of the decline that we all have with aging. We know that lung function impacts our risk for lung disease over the lifespan. So low lung function during early life is a risk factor for COPD later on, and that air pollution is a risk factor for childhood asthma. And so thinking about the indoor air as another arena for exposure and the importance of the indoor environment. This is data from about just under 10,000 Americans from about 20 years ago, demonstrating that we spend the overwhelming proportion of our time indoors. And some of the studies that we've done would suggest that we spend even more time than this indoors, and that most of that time is in our own home, with children also spending time in schools and adults during usual times in the workplace. I'm going to share some results from work we've done in Baltimore City, and I've been fortunate to be part of the Center for Childhood Asthma in the Urban Environment. And I'm just going to take a moment, and this was just raised, to discuss some of the features of the study design and the results I'll show and communicate with you. Indoor air quality studies take a lot of different resources, and typically the sample sizes are much smaller because of the intensity of the study protocols. And so here, I'm sitting here in Baltimore City right now, and this is an area right around our medical campus where many of our study participants reside. And this is a typical row home in Baltimore City, and many of our study participants live in a home like this, with shared walls and close proximity to the roadway. And in the bottom left is an example of the type of monitoring setup that we would place in a participant's home and leave there typically for about a week, so that we capture each weekday, which maybe represent different behaviors in a home. And then we typically go and do this multiple times to capture seasonal effects and changes that occur over time. So these are results from a study on preschool children with asthma living in Baltimore City. And I want to draw your attention to a few things. One is this box plot right here represents the indoor fine particulate matter in children's bedrooms compared to the outdoor particulate matter that was measured during the same time period. And you can see that in these children's homes, the indoor particulate matter concentration was much higher than the outdoor concentration. And in red, this was the outdoor standard for set by the EPA at the time of the study, which was 15. And we can see that 3/4 of the children lived in homes that would have exceeded that standard if we looked at their indoor air quality at that time. We compared this to children living in suburban homes and found here that the inner city homes had exaggerated and elevated concentrations of indoor fine particulate matter compared to suburban homes. And we were interested in the health effects. And so this figure demonstrates the relationship between increases in indoor particulate matter on the y-axis and different respiratory outcomes on the x-axis. And these are different types of respiratory symptoms: cough, wheeze, chest tightness, symptoms with exercise, symptoms at night. And in the final category, the need for children to use a rescue inhaler due to problems with their breathing. And we found a consistently positive association, meaning that increases in indoor particulate matter were associated with increases in asthma symptoms and the need for rescue medication among these children. This is a study that was done in Southern California in a group of 20 children. The last study I showed you was done in a cohort of 150 children. So these are relatively small studies. This study in Southern California looked at, used personal monitoring to capture childhood exposure, which was largely from indoor environments, and demonstrated a link with lung function. And so here you see multiple different, the investigators looked at different time windows of exposure, but what you see is a consistent relationship such that increases in fine particulate matter exposure were associated with reductions in lung function, in this case, the FEV1. We know that children, in addition to their homes, spend a great deal of their time in school environments. On average, during typical years, this would be about 6 to 10 hours per day. And a unique feature of schools is that many children are there for a given period of their time. So the school environment has the potential to impact communities on a broader level. Very few studies have directly assessed school environmental conditions, in part due to the complexity of indoor air quality studies. I wanted to highlight two studies that are looking at the features of indoor air in school environments. On the left, these are studies from a group in Boston that have focused on the northeastern school district. And on the right represents the Mid-Atlantic School District and work I've been fortunate to be a part of here in Baltimore. Both of these studies studied about 30 schools in an inner city school district and performed with very similar designs. And I have a picture of our setup there on the left. And we went in for 2 weeks at a time in each school and studied the school in the fall, the winter, and the spring. And during those times, we would set up a monitoring station in a classroom or a common space like a cafeteria or gymnasium. The Northeastern School District had a very similar protocol. And we both found that on average, the indoor air quality was within reasonable limits, with an average PM 2.5 of about 5 in both studies. In the Northeastern School District, they also focused on sources and found that there were outdoor contributors to indoor air quality, as well as behavioral and activities that were occurring in the indoor spaces. In our study in the Mid-Atlantic region, we also focused on the impact of school renovation. And in about half of these schools that we studied, they subsequently underwent a major renovation. And we found that improvement in school facilities was associated with improvement in air quality and reduction in fine particulate matter concentration. So even though the baseline level was within a reasonable range, that modernization of school facilities led to even better air quality. Thinking about asthma, I also wanted to mention this work that was recently completed, led by Dr. Sonali Bose. This is an adult study of asthma, again with a similar study design, and here data from 61 non-smoking adults with asthma. and demonstrating that on average, here on the far right, we see all seasons combined, that on average, the individuals were living in homes with a median PM fine particulate concentration of about 22, so about double what we would think is an acceptable indoor limit. So room for improvement in their indoor air quality. And again, consistent findings suggesting that higher baseline levels of indoor PM were associated with increased respiratory symptoms among adults with asthma, and that changes within an individual's home, such that increases in indoor particulate matter were associated with worsening of asthma symptoms. I wanted to turn to another common respiratory disease, which is COPD. And when we think about the global burden of COPD, indoor air quality is certainly a well-recognized contributor, particularly in low and middle income countries. We think about the exposure that affects women as well as children relating to indoor cooking practices and biomass fuels. There have been interventions worldwide to think about targeting indoor cooking sources and cook stoves and improvements in ventilation. In the United States, solid fuel use continues to be an important issue that has health implications. And here we see a map of the United States, and in darker purple, we see increased prevalence of solid fuel use, which affects over 6.5 million people in the US currently. And there's an overlap between solid fuel use and poverty in the United States. On the right here, we see proportion of households below the federal poverty limit and federal poverty line. And we see that as the shading is darker, that's increased proportion of households. And if we align these two maps, there are between 500 and 600,000 people that are living in households below the federal poverty line that also use solid fuel use. Studies have demonstrated a relationship between solid fuel use and COPD, as well as respiratory disease. I was fortunate to work with Dr. Sarath Raju using data from the National Health Interview Survey and Haynes, and showed consistent results that heating with solid fuels was associated with increased COPD among never smokers in both of these studies. And also the BOLD study, the Burden of Obstructive Lung Disease Initiative, has demonstrated that indoor cooking with wood and coal is associated with increased asthma prevalence, focused on a southeastern Kentucky population. We were interested in extending this with more granular detail and partnered with investigators from East Tennessee State University to conduct environmental cohort studies with a focus on COPD. And these are results from our cohort in Baltimore City, where compared to the populations that I showed you with children with asthma and adults with asthma, the indoor particulate matter concentrations in these homes, and this is about a little over 100 participants, was relatively low with an average of about 11 micrograms per meter cube. But even at these lower concentrations than our other study populations, we saw that increases in indoor particulate matter were associated with increases in COPD exacerbations, respiratory symptoms, and the need for rescue medications. We also found that during warm months, there was a synergistic effect, so that increases in heat were associated with worse outcomes among those individuals living in higher particulate matter homes. Findings from our partners in Appalachia, we had conducted a very similar cohort study in 50 individuals. And here again, these participants were studied at baseline and with follow-up at 3 and 6 months, and found that increases in indoor particulate matter were associated with increases in respiratory symptoms with worse health status, as well as symptoms of rhinitis. We looked at our cohort studies to try to understand whether there were distinct factors at the individual level that might confer increased susceptibility to the health effects of fine particulate matter. And one of the factors we were very interested in was obesity, given that obesity and overweight is an increasing health problem across the world, and particularly across the US, and it also impacts poor communities and individuals that are living in poverty to a greater extent. And this is work that was led by Dr. Matsui, and here, this was a cohort of 150 children with asthma. And what I wanted to draw your attention to on this somewhat busy slide is that we stratified the children into normal weight, overweight, and obese. And these are similar symptom outcomes that I showed before with respect to respiratory symptoms of asthma in children and this rescue medication use. And what you see here is in the middle row, there's the greatest effect was seen among children that were in the overweight category. And here we see this synergistic effect with increases in PM and increases in BMI when these two circumstances were both in effect. We saw increases in the symptoms of cough without a cold. We found a similar trend when we looked at secondhand smoke and found that children had increased symptoms in response to secondhand smoke that was much exaggerated among the overweight and obese groups compared to the normal weight group. We hypothesized that, and this was something that Dr. Kippen was just talking about, thinking about our breathing rates. We hypothesized that this could have to do with increases in tidal volume that occur with obesity to try to better understand why we were seeing this signal with obesity. And in a recent study, we were able to measure tidal volume in children with asthma and found that there was an association between increasing BMI and increasing tidal volume. And when we modeled this, we found that BMI was associated with increased particulate matter deposition rate. So potentially this is a characteristic important among children with obesity. And finally, we saw that this was similar in our cohorts of individuals with COPD, suggesting that obese individuals had a greater response to particulate pollution, seen here for both shortness of breath and probability of wheeze compared to the normal subgroup. And finally, we'll talk about this more in the sessions next week, but I just wanted to comment on environmental intervention studies as a means to contribute to the causal framework. We've seen that there are associations between exposure to indoor particulate matter and respiratory outcomes, and studies that look at and investigate the effect of interventions to reduce indoor particulate matter can provide further evidence of the respiratory health effects. And in brief, two studies just to highlight in anticipation of next week's sessions. One, the PREACH study looked at children with asthma with an air purifier intervention and found that reducing PM by 50% resulted in improvement in symptom days. And a recently completed study, the Clean Air trial, had a similar approach in adults with COPD and randomized individuals to active or placebo air purifiers and found improvement in respiratory health status as well. So really, in conclusion, indoor particulate matter concentration in the indoor environment is a contributor to health disparities. And in particular, I've highlighted the impact on two very common respiratory conditions, asthma, which affects children through adulthood, as well as COPD. And individual characteristics like obesity may confer increased susceptibility, and ultimately improving our air quality may serve as a therapeutic target and a preventive strategy for respiratory disease. Thank you.